Hello. Can
Yes,
we start?
Yes, suppose
Supporting,
start in
can I
3,
start?
2, 1. Please start, ma'am. We are live.
Okay. Hi, good evening, everyone. And Namaskar and good evening, everyone. I welcome you all for the webinar on management of hepatocellular carcinoma. And with immense pleasure, I would like to invite Dr. Srinivas PJ, who is medical oncologist at HCG Bangalore, for the welcome and introductory note and to take the proceeding further. Over to you, sir.
Yeah, thank you. So, thanks everyone for joining for this session. This is based on hepatocellular carcinoma and pancreatic cancer, which we are doing, and elite speakers and panelists are there. Dr. Kiran from Mysore, Dr. Sai Vivek, Dr. Indu Shekhar, our senior consultant, who is speaking especially on liver-directed therapies, and Dr. Vaishnavi Joshi from Aster, Dr. Ravi Tippeswamy, and our elite panelists, Dr. Mansi, Dr. Satish, Dr. Vishwanath, and our senior faculty from Manipal Hospital, Dr. Punam Patil. So all good academic feast is lined up for a 2 hour session. Thanks for joining and giving time for this meeting. And so hepatocellular carcinoma and pancreatic cancer, we know it's a being aggressive tumor, and definitely it requires multidisciplinary team approach, including surgeons, radiation oncologist, interventional radiologist, and especially metastatic cancer. We are focusing more on metastatic cancer, where the both pancreatic cancer and hepatocellular carcinoma has a dismal prognosis. So many newer treatments are coming up one by one. I think we are focusing on those modalities of treatment. With this brief introduction, I think I would like to welcome Dr. Kiran from JSS Hospital, Mysore, for his talk on newer approaches in the management of metastatic pancreatic cancer. Dr. Kiran, over to you.
Yeah, good evening, sir. Good evening, everyone. Thank you very much for inviting me for today's webinar. So, I'm going to present regarding a topic like recent advances in the management of CA pancreas. Just a second, I'll share the screen. Is it visible?
Yeah, sir, just make it full screen.
Yeah, it is visible.
Yeah.
Sure.
Now, as Dr. Srinivas mentioned, like.
Hello.
Yeah. Is it audible? Hello?
Yes, sir.
Yeah. Kiran, you can go ahead.
Yes, sir. So, pancreatic cancer is one of the most aggressive tumors. We have seen like the overall survival is hardly around some 8 to 10%, and majority of the pancreatic tumors will be diagnosed in the advanced stages. So there are very minimal options. Many of us know that what is the first line of treatment and what is the second line of treatment for CA pancreas, and the third line of treatment, what next? That is the question now. So it's a great question like what is the next option where we can provide to the patient regarding the treatment for CA pancreas. Now, coming to the prognostic factors in metastatic disease, in advanced disease, the factors defining a worse prognosis are determined from the all key phase 3 trials. It all depends on the impaired general condition as per the ECOG performance status, age more than 65 years, albumin less than 3.5 gram per deciliter, 3.5 gram per liter, and 3.5 presence of synchronous metastasis and high serum CA19 levels. All these are poor prognostic factors. If the patient has any of these factors, metastatic CA pancreas. Now, as I told you that the first line of treatment, as we all know, it is FOLFIRINOX or gemcitabine plus nab-paclitaxel or gemcitabine plus platinums, and gemcitabine alone, or the recent one is NALIRIFOX. So, how this treatment regimens arrived? It was in 1997, where initially gemcitabine was the single agent. Gemcitabine was the only treatment of choice for metastatic CA pancreas. Then later came the study, that is phase 3 PRODIC 4 or ACCORD 11 study where the study design was, it was like 342 patients were enrolled for two arms. One is FOLFIRINOX and one is gemcitabine as a single agent. Here, FOLFIRINOX, the dosages has been the same, what we use. Like next, there were 6 months of chemotherapy was given and CT scans was performed every 2 months. Later, this is the overall survival where the curves are departing at the early only when compared to gemcitabine alone. FOLFIRINOX has a clear-cut benefit with hazard ratio of 0.57. At a median follow-up of 27 months, FOLFIRINOX improved overall survival. That is, median overall survival was 11.1 months for FOLFIRINOX versus 6.8 months. And PFS benefit is also there, where median PFS was 6.4 for FOLFIRINOX versus 3.3 months for gemcitabine single agent with hazard ratio of 0.47. So then later it was like FOLFIRINOX became the standard first line of treatment for metastatic CA pancreas if the patients and well-tolerable patients. Now, the next line of treatment was nab-paclitaxel plus gemcitabine. This was IMPACT trial, where the study design was, it was 842 patients who were randomized for either combination of nab-pacli plus gemcitabine or gemcitabine alone with 1:1 stratification. Primary endpoint was overall survival, and secondary endpoint was PFS and overall response. 6 not 8 events, 90% of the power to detect, and overall survival hazard ratio 0.769. CT scan was performed every 8 weeks here. So this was the result, where at median follow-up of 9 months, the addition of nab-paclitaxel to gemcitabine has improved the overall survival to a median, like median oral survival was 8.5 months versus 6.7 months with gemcitabine as a single agent with a hazard ratio of 0.72. Median PFS was 5.5 months with the combination treatment, whereas 3.7 months with gemcitabine alone. So, and a clear-cut benefit with the addition of nab-paclitaxel to the gemcitabine. So, if patient is having a poor ECOG performance and bilirubin levels are like more than or equal to 1.5, then the second option would be the first line of treatment for advanced metastatic CA pancreas. Second option would be gemcitabine plus nab-paclitaxel. Now, the third option is Napoli 3 study, that is NALIRIFOX, where it's a randomized open phase 3 trial. The data was out in 2023. Patients were randomized between liposomal irinotecan 50 mg per meter square plus 5-FU plus leucovorin plus oxaliplatin once in 15 days versus gemcitabine plus nab-paclitaxel, and the treatment was continued until disease progression or unacceptable toxicity. There were patients who were continued this treatment for another more than 10 cycles, 12 cycles and all, where oxaliplatin was stopped because of peripheral neuropathy and patient tolerated it well. So the primary endpoint of the study was overall survival. Secondary endpoint was PFS and overall response rates. The patient characteristics were well matched between both the arms, where the baseline CA19 levels and the tumor location, everything was well matched, and also the liver metastasis. So this is the overall survival. Even though the survival benefit was 2 months approximately, the p-value was significant with a 0.04. The median overall survival was 11.1 months for NALIRIFOX versus it was 9.2 months for gemcitabine plus nab-paclitaxel with a hazard ratio of 0.83. So in all the other subgroups, like number of metastatic sites, ECOG performance status, and region, Caucasian or the rest of the world, North American or site of the disease, everything all favored nalfirox over gemcitabine plus nab-paclitaxel. Now, this is the PFS data where nalfirox has a median PFS of 7.4 months versus 5.6 months for gemcitabine plus nab-paclitaxel with hazard ratio of 0.69. So once again, in all the subgroups, PFS data in all the subgroups, it favored nalfirox. So the tumor response rates were objective response rates were 41.8 versus 36.2 with the jump plus nab-pacli, and complete responses were almost similar, and the other responses were almost similar, but slightly higher responses of partial response in nalfirox. So coming to the safety of nalfirox, the median treatment duration 4 point jump plus nab-pacli, grade more than or equal to 3 adverse events were almost similar between the two arms, and serious treatment-related adverse events were also similar between the two arms. The major side effects with the nalfirox was diarrhea, nausea, vomiting, and neutropenia were almost similar between both the arms, and peripheral neuropathy was almost similar. Main thing was the diarrhea because of the liposomal irinotecan. So the conclusions of this Napoli-3 trial was it's a phase 3 study where first-line nalfirox statistically significantly prolonged overall survival and PFS versus GEM plus nab-pacli in patients with metastatic pancreatic cancer. The overall survival and PFS benefits were generally consistent across various patient subgroups, and no new safety signals were. So because of this, they concluded that these results support the use of nalfirox as a new reference first-line regimen for metastatic pancreatic cancer. Now, this is a flowchart where what we do for second-line treatment, like if the ECOG performance score was 0 to 1, bilirubin levels less than 1.5, and no major comorbidities, then the first-line treatment would be FOLFIRINOX, and the second line would be gemcitabine nab-paclitaxel. If patient is not tolerable, then we go for gemcitabine nab-paclitaxel as a first line, followed by, in the second line, if patient has already become gemcitabine refractory, then we can always think of nalfirox. But as per the Napoli-3, nalfirox should be considered as a first-line treatment for metastatic pancreatic cancer. Now, apart from this, apart from first line and second line, there are few other precision data where precision medicine plays a role in pancreatic cancer because of number of mutations which occur in CA pancreas. In this, the main mutations are, one is BRCA mutations, which is seen approximately in 5 to 7% of the Caucasian patients which harbor a germline BRCA mutation, where a randomized phase 2 trial in patients with germline BRCA mutations demonstrated a high response rate for gemcitabine plus cisplatin, where patients have received a platinums, where patient has received gemcitabine plus cisplatin. These patients can be treated with the maintenance olaparib, which showed that POLO trial, which has shown some efficacy with the maintenance of olaparib in BRCA positive patients. Here, the median PFS was significantly improved by olaparib versus placebo. It was 7.4 months versus 3.8 months. The next marker will be MSI high or MMR deficient patients. The frequency is approximately 0.8%. In some papers, it is 1 to 2%. And in a prospective non-randomized trial, where small number of patients who are MSI high were treated with pembrolizumab, there was 1 complete response and 3 partial response, where the median PFS was 2.1 months and median overall survival was 3.7 months. So further data needs to be done. Because of the lower mutation analysis, this other studies are not available. So NTRK fusions occur in KRAS wild-type tumors and in more than 1% of all pancreatic cancers. They are targetable with specific inhibitors like larotrectinib and entrectinib. So these are the 3 important mutations where BRCA mutation will go for maintenance olaparib after treatment with a platinum-based regimen, that is gemcitabine plus cisplatin. And in MSI high tumors, pembrolizumab can be considered and NTRK fusion positive tumors, larotrectinib or entrectinib can be considered. Other mutations like KRAS mutations are common in pancreatic cancers, where KRAS inhibitors can be used for sotorasib and adagrasib, which are molecularly targeted agents, which specifically inhibits KRAS G12C mutation, which are acceptable alternatives. If patient is not eligible for chemotherapy, or if patient refuses chemotherapy, then these are the treatment of choice for metastatic CA pancreas. Other one is BRAF V600E positive mutations, where dabrafenib and trametinib has a role. These patients should be initially treated with chemotherapy, first-line chemotherapy, either FOLFIRINOX or NALIRIFOX. No other alternatives are there, then these patients can be tried on dabrafenib plus trametinib. So RET fusion positive tumors, once again, selpercatinib has accelerated approval from the US FDA for the treatment of adult patients with locally advanced and metastatic solid tumors with RET gene mutation that has progressed on or following prior systemic treatment, or who have no satisfactory alternative treatment options. And once again, HER2 positive tumors, trastuzumab deruxtecan is an option for later line therapy. So there are many treatment options. Only thing is, we have to go for NGS tumor panel in all metastatic CA pancreas, and then we need to decide the treatment options. Thank you.
Yeah, so well presented, Dr. Kiran. So have you, what is your choice of treatment when first line pancreatic cancer you have have you experienced giving this liposomal irinotecan combination or um,
No, sir,
gemcitabine and nab-paclitaxel?
I have no experience with liposomal irinotecan, but for all young patients and fit patients with good performance status, definitely I'll go for FOLFIRINOX. I have patients who have received FOLFIRINOX for 12 cycles, followed by then I have stopped oxaliplatin and continued with only FOLFIRI regimen for these patients, and they are tolerating it well. Almost they are continued for around 10 months and all, doing well. And for all elderly patients, usually I go for a combination of gem nab-paclitaxel with deranged LFTs.
So yeah, I think most of the patients with metastatic pancreatic cancer definitely have a performance status will not be, most of the patients will be either 2 or 3 performance status. Only around 10 to 20% of them will have only performance status of 1. And I have experience of giving this liposomal irinotecan. Definitely it is well tolerated compared to the FOLFIRINOX, I think most probably. So, yeah, most of the choice now, if patient performance status is good, I think we will go for this liposomal irinotecan. Otherwise, gemcitabine and nab-paclitaxel. And even whatever the NGS markers you were mentioning, BRAF mutation, NTRK and all, I think less than 2-3%, I think. So
Yes,
most of the patients will not go for it. So chemotherapy is the treatment of choice in most of the patients, and most of them are not able to tolerate the aggressive regimen. And if they tolerate, I think liposomal irinotecan is going to be a better drug as of now, as I think most probably. So even failure of this gemcitabine and nab-paclitaxel, I think we can give this liposomal irinotecan as a second line agent also, along with the 5FU. I think this is one of the good addition for the patients with metastatic pancreatic cancer. Thank you, Dr. Kiran, for your wonderful presentation. So please stay with us if you don't have any emergency work. I think you can stay on, and we can have some more discussion at the end for the panel discussion.
sure, sir.
So,
Thank you, sir.
Thank you. Yeah, I would like to call upon Dr. Sai Vivek for our sponsored session by AstraZeneca. So this is the Sai Vivek is a medical and hemato-oncologist from Aster Hospital, Bangalore. He will be talking on real-world evidence from India, especially for durvalumab and Gemcis combination, which is a new standard of care in advanced biliary tract cancer. Over to Dr. Sai Vivek.
Yeah, thank you, sir, and good evening, everyone. I would like to first thank the organizers for this opportunity. I hope I'm clearly audible and my slides are visible. Um,
Yeah.
Thank you, sir. So I think the topic given to me today is real-world evidence for durvalumab plus gemcitabine and cisplatin as the standard of care in advanced biliary tract cancer. So this would be the overall flow of the presentation. We would briefly try to cover all these topics. So starting off with epidemiology, as we always do, numbers are in the end numbers, but as we all know, biliary tract cancers, especially the gallbladder cancers, the incidence rates are on the rise. We are seeing more and more biliary tract cancers in the last few years as compared to before. Biliary tract cancers rank as the 19th most common cancer and the 15th most common cause of mortality in cancers. But what is interesting to know here, or what is really sad to know here, is almost 80% of the cases have mortality. So 21,780 new cases with around 16,407 deaths. So it is a very aggressive cancer with overall poor prognosis, is what we know about the biliary tract cancers. So in India, there has been a study published by the Command Hospital in Lucknow, where in this retrospective study, when they saw 245 patients of gallbladder cancer, and they found that most of them were coming from the Ganges belt, especially Uttar Pradesh, which is around 73%, followed by Bihar, Jharkhand, Uttarakhand, and Madhya Pradesh. So the whole Ganges belt, I think, is a hotspot for biliary tract cancer, and we see a lot of patients from West Bengal also presenting with advanced biliary tract cancers, especially the cancer of the gallbladder. So there has been a increase over the last few years for cancers of the biliary tract, and a high index of suspicion is required even in young patients in high incidence areas. So this is the 25-year GBC incidence data from the Cancer Registry of Delhi. One important thing to note here, if you look at it from the 90s, early 90s to early 2000s, there's nearly a tenfold rise in the incidence of biliary tract cancer, especially gallbladder cancer, which again reiterates the fact that all of us should be on top of our game in terms of finding out the latest treatment options for biliary tract and what are the different standard of care approaches that are given as per the guidelines. So the current management of advanced BTC, it's very crisp in this particular slide by ESMO recommendations. So upfront at diagnosis, we first classify them into early stage, locally advanced or metastatic. So in both locally advanced or metastatic, after sending the molecular profiling at diagnosis, ESMO recommends initiation of gemcitabine cisplatin plus durvalumab or pembrolizumab as a category 1A recommendation. So there is enough evidence from strong randomized controlled trials that this should be the standard of care for locally advanced or metastatic cancers. So depending on the response, some of the locally advanced might go up for curative surgery, but in the metastatic setting, this stays as the standard first line option. The second line options, yes, we do have FOLFOX or FOLFIRI if there are no driver mutations that are found during our molecular profiling. So we all know about the different driver mutations that are present, and we all test for them routinely in our clinic. So because of this, even NCCN, it's a category 1 recommendation in advanced BTC to start gemcitabine cisplatin, durvalumab, or pembrolizumab. So this particular recommendation came from our Topaz 1 study, which was a phase 3 randomized double-blind placebo-controlled multi-center global study where upfront metastatic biliary tract cancer patients or patients who had a recurrence 6 months after curative surgery or adjuvant therapy were randomized in a 1:1 fashion to Gemcis durvalumab versus Gemcis plus placebo. The primary endpoint here was overall survival, a good number of patients, almost 340 in each group. And here we have the updated overall survival. Before we go to this, one thing we need to know that over 54% of the patients in this particular study were gallbladder cancers. and intrahepatic and extrahepatic cholangiocarcinoma constituted 18 and 24%, if I'm right. So 50% of the cancers were gallbladder cancers. If you look at the updated 24-month overall survival, there is definitely a separation of the curves. But here, what is interesting to see at the 6 months period, up to the 6 months period, there is a rapid decline in the number of patients who are progressing, and then there is a survival deficiency in them. So up to 6 months, we don't see real benefit, but after 6 months, we see the curve separating. That in the clinic tells us there is a subset of patients. So a subset of patients definitely do respond to this therapy. And if they do respond, slowly we are seeing plateauing of the curves. So here, as we see at 2 years, the overall survival is 11.5% versus 23%. That is 1 in 4 or 1 in 5 of the patients are still alive at 24 months. So that particular 1/4 of the patients whom we diagnose might actually benefit from this regimen and end up having a prolonged survival or better overall survival compared to just chemotherapy alone. The median overall survival is 12.9 versus 11.3 months. So these are the PFS curves. Again, observing the first 6 months, there is a rapid decline in both the curves in the first 6 months, and then slowly as we touch the 6 to 9 months duration, we do see that particular subset of patients who end up being responders compared to the other curve, which continues to decline. So the overall response rate is around 26% versus 18.7%. And here, the duration of response, if the patient has responded, then remaining in response for over 9 months was seen higher in the immunotherapy arm, as we see with all the other immunotherapy molecules. It was 32.6 versus 25.3%. So this is the curve that is more important. So patients who responded continue to respond better and beyond 2 years. So 2 years, or rather even 12 months, was very rarely seen in metastatic biliary tract cancers. Most of us had our overall survival at around 9 months to 12 months, but some people going on to 2 years, especially the responders who get a CR or a PR in the initial 4 to 6 months, their median overall survival touches 20 months or close to 2 years. So right now, there are no biomarkers to suggest who responds, but to find out who that 1 in 4 patient is, I think the standard of care should ideally be Gemcis plus immunotherapy durvalumab or pembrolizumab in the first line setting for our biliary tract cancers. Next, going on to the forest plot for the subset analysis. Here, as we know, most of the patients were gallbladder cancer, but the people who had the maximum responses were the cholangiocarcinomas, especially the extrahepatic, but these are very small numbers, so let's not read into it much. But what is important is the maximum benefit was seen in the cholangiocarcinomas, especially the intrahepatic cholangiocarcinoma. I'm not going to spend much time on the safety profile. We're all now well versed with the management of immunotherapy-related adverse events. So as we know, we do send for the molecular profile in the upfront setting. So they also looked into, depending on the molecular profile, is there a change in the response rates or the survival rates? So the most common genomic alterations that they saw were the TP53, CDKN2A, KRAS, ARID1A, and apart from that, the actionable IDH1, HER2, BRCA1 and 2, BRAF, and FGFR. So in this particular analysis, we do see in which molecular mutation was the response not seen. So one thing to remember or take home would be, if there is a HER2 amplification, that is ERBB2 amplification, we can say that the response would be lesser. And that goes along with our common understanding that whenever there is a driver that is present, the role of immunotherapy does become slightly inferior. So in HER2 amplification especially, we do see that the response rates are poorer. Moving on from the TOPAZ-1 study, which is a clinical trial where the patients are very carefully selected, good performance status, everything designed to show some difference to real-world studies. We are going to be talking about 3 real-world studies, 2 from Italy and 1 from our own India. So this is the first study from Italy, the real world evidence for biliary tract cancers. Most of the patients here were intrahepatic cholangiocarcinoma and followed by extrahepatic cholangiocarcinoma and carcinoma of the gallbladder. So what again they found, the median overall survival was very similar to that seen in the TOPAZ-1 study at 12.9 months. And the median PFS was 8.9 months, again mirroring the data from TOPAZ-1, hence showing a good reproducibility of the regimen in real world setting. The second real world study is again from Italy. Here, a good number of patients, almost 666 patients. They did have patients from other countries also, and it was 39 sites to be specific. And what they again found in this particular real world study, the hazard ratio for overall survival was 0.59 and it was 0.57 for progression-free survival. So this again mirrored the results seen in the TOPAZ-1 study. So this is the study from India published by Dr. Vamshi Krishna from AG Hospitals and multiple other centers, to be 12 to be specific. So all over the country is well represented in this particular real world study, and a total of 148 patients were included in the study. Most of them again were gallbladder cancers at 63%. Like the TOPAZ, that was the predominant, followed by intrahepatic cholangio and extrahepatic cholangio. And what they found again was the median PFS was very similar to the TOPAZ-1 study at 8.2 months, and the median overall survival was nearly mirroring it at 12 months. So the adverse events were again similar, no new safety signals. So all these three real world studies do conclude that the real world experience mirrors that of the TOPAZ-1 global clinical trial. No new safety signals. Patients with poor performance status also seem to tolerate the addition of durvalumab. The Indian data does confirm the same thing. So to conclude, TOPAZ-1 establishes durvalumab plus Gemcis as the standard of care for managing unresectable biliary tract cancers. Adding durvalumab to this does not worsen the toxicity profile, showing comparable safety. The combination is effective in patients with clinically actionable and high prevalence genomic alterations. To take this with only ERBB mutations, we need to be slightly more careful in the first line setting. But as of now, the first line standard of care, according to NCCN and ESMO, is still Gemcis plus immunotherapy, irrespective of what mutations are present in the first line setting. So the real world evidence from India also confirms the same. So that would be my last slide. Thank you. And I would be handing it over to the organizers.
Yeah, thanks, Dr. Sai Vivek. What is your, you are able to reproduce the same in your same numbers in your clinical practice, response rates wise?
Yes, sir. I think recently we had even sent an abstract to the main ESMO last week, sir. We had around 16 patients with biliary tract cancers in the last 1 year. So we just went back 1 year and saw the median PFS was 7 to 8 months. The overall survival was 10 to 11 months. We felt it was slightly lesser compared to the TOPAZ-1, but I think the numbers are very small for us to draw many more conclusions from that. But almost similar to slightly lesser, definitely not better than what TOPAZ-1 says.
Okay. And the side effect profile wise?
Side effect profile is well tolerated, sir, because cisplatin, we split it. In this particular regimen, we give cisplatin day 1 and day 8. I think that makes it much more tolerable. Hence, most of the patients could complete the treatment, but there were many non-responders as we found.
Yeah, I think in our practice also we are able to reproduce the same response rates, and I think we have not tabulated or we have not gone back for reviewing that, but definitely response rate wise and quality of life, definitely there is improvement with addition of the durvalumab immunotherapy, and as most of the people are able to tolerate, we are not finding any significant side effect from the immunotherapy as such. I mean, in your clinical practice, you do this NGS upfront or whatever they have shown in the TOPAZ study, or only at the end after the progression of the disease?
No, we do send it at diagnosis. So once we have diagnosed the patient, just before we start the first line treatment itself, we have the NGS sent and the treatment for second line planned. because we know
Suppose
that
this patient,
there is.
any patient comes with HER2 positive or HER2 amplification, as it was there, there was no response. So then, what will be your
So personally speaking, this is just my opinion. We do have the HER2 positive data from TMC in India, especially in gallbladder. That is the caveat here. So in gallbladder cancers, which are the majority in our country, if at all I do see HER2 in the upfront setting, I would be more tempted to start off gemcitabine, cisplatin plus anti-HER2 treatment rather than immunotherapy. We do have our own Indian data to support that.
Yeah, I think thanks, Dr. Sai Vivek. I think yes, most of our patients we see in our clinical practice, they come from this northeast. That whatever epidemiology is there, so most of the patients from northeast country states. So definitely, with addition of the immunotherapy, most of our patients have done well with the treatment option. So I think I request you to stay till the end, and we will move on to our next speaker, Dr. Indushekhar. I will call upon Indushekhar. So he's a senior interventional radiologist from HCG Bangalore. So he will be guiding us through the liver-directed therapies in HCC. We hear a lot about the TACE, STAIR, and all other procedures. So we would like to hear from his personal experience integrating loco-regional and systemic approaches, because the hepatocellular carcinoma, we have both the loco-regional therapy and systemic therapy is combination is the treatment of choice nowadays. So I think I would like to call Dr. Indushekhar for his presentation. Sir, Dr. Indushekhar, sir.
Actually, I don't. I'll just open my presentation. Are you able to see my presentation?
No, we are able to hear you. We are not able to see your presentation.
No, why? Actually, I am unable to share this
Yeah, they will help
PPT.
you out, sir. Just a minute.
Sir,
Yeah.
should we share it from our end?
Yeah. Do you have it? I had
Can you
sent
share
the
it?
mail. I sent
Okay.
it by mail.
No, they
Okay.
have
Uh,
they have, I think, most probably.
Can you? There is no icon for sharing.
I think you joined from a different link, I think, sir. I
No,
think
no, same.
same link, huh? Okay.
Yeah, same link.
Sir, you have shared on which email?
Huh?
Hello.
Hello.
Yeah, so on which email you have shared the slides?
Yeah, can you see now?
No, sir, we
No.
can't see your screen.
There is no option of sharing in the screen which
Can
I
you share
opened.
your PPT slides with us so we will share it from our end?
I have sent it to you. I've
Support team, can we guide doctor? Why he's not able to see the share screen?
I'll send the mail again.
Sure, sir, please.
Okay, I'm just. Have you sent by mail drop?
2 minutes, sir. I think they're able to share 2 minutes.
There is no option of sharing in the screen when I've opened
Okay.
the webinar. I don't know, there's some technical problem, I think.
Sir, we are unable to find your PPT on mail. Can you just send it us on WhatsApp? Is that okay?
Well, from my computer, I don't think I can send by WhatsApp.
Just a moment.
So tell support team, are you there? Who is there from support team?
Ma'am, please, sir, please back to Zoom. Hello.
Hello?
Yes, sir. Back to Zoom application, sir.
Yeah, I'm trying, but
सर आपका जो टास्क बार है ना वहां पे ओपन होगा जूम, वहां पे क्लिक कीजिए।
no way. Not happening. Actually, this is my Apple laptop. So
ओके,
I don't
तो जहाँ पे सर आपका जो एप्लीकेशन शो कर रहा है ना, डेस्कटॉप पे चले जाइए एक बार।
Pardon?
आपका जो मैक का जो डेस्कटॉप
English.
होता है ना,
I think you need to speak in English, I think.
Okay.
Or else, shall we move on? Support
Yeah,
team,
yeah,
we can.
please move on. We'll try to
By the time
correct.
you just make it ready, sir, you can send it by WhatsApp, or you can send it to my email, sir. Mail ID, I will send. I will give it to you. We will move on. Dr. Vaishnavi,
Okay.
are you ready? Dr. Vaishnavi?
There is no caption of share the PPT.
Sir, you mail us or mail to Dr. Srinivas. Dr. Vaishnavi, are you there?
Hello?
Sarangi, please call Dr. Vaishnavi.
Yeah, I'm just calling. She has joined already, but she's not picking the call.
She is muted. She's muted actually.
Dr. Vaishnavi is here.
Yeah, I'm here.
Yeah, I think we are having. Dr. Vaishnavi, are you ready?
Yes, sir.
Yeah, so we are having a technical problem with Dr. Indrashekar. I think we'll move on to your
Okay.
presentation.
Sure,
So Dr. Vaishnavi is from Master CMI Hospital, consultant medical oncologist. So we have now more and more options for hepatocellular carcinoma, and she will be talking about one of the stride regimen in first line advanced metastatic hepatocellular carcinoma. It is a sponsored special session by AstraZeneca. So please go ahead, Dr. Vaishnavi.
Yeah, can I share my screen? I think somebody else is
Yeah.
sharing. One second. Yeah, is it visible?
Yes, ma'am. Just make it full screen. Yeah.
Yeah. Okay. Okay, thank you so much, Dr. Srinivas and AstraZeneca for this opportunity. I'll be talking about transforming patient outcomes with innovative therapy in advanced unresectable hepatocellular carcinoma. So, as we know, liver cancer contributes to significant mortality and morbidity across the world. And about 45% of cases worldwide presents the liver cancer presents when it has already metastasized to other organs or lymph nodes. Hence, the prognosis has remained dismal in these patients. So as far as India is concerned, the incidence is increasing, and the incidence of hepatocellular carcinoma in cirrhotics in India is about 1.6% per year, and about 50% or more, as we see in our practice, present in advanced stage, such as BCLC C and D. So what contributes to hepatocellular carcinoma development in patients with this liver disease? So as far as etiology is concerned, it could be hepatitis B or C, or it could be a metabolic syndrome, NASH, or chronic alcohol abuse. So all this leads to cellular stress and deregulated liver immune network. This has been suggested now, or inflammation related to deregulated immune network in the liver, which is
Hello, Dr. Vaishnavi.
Actually, there is some network issue with ma'am. Let me just check. Hello, Dr. Vaishnavi. Can you hear us?
She is not reachable.
Actually, she's not picking up the call. Let me just check.
Okay, so Dr. Indushekar's slides are ready.
Yeah, sir.
Okay, we'll wait 1 minute, one more minute. We'll see whether she is able to come up.
Hello, Dr. Srinivas. Actually, Dr. Vaishnavi ma'am is not picking up the call, so can we just
Yeah,
start Dr.
with Dr. Indushekhar. Yeah, we'll start with Dr. Indushekhar. Yes, sir. Please go ahead, sir.
Okay. Thanks, Dr. Srinivas and the entire team for giving me an opportunity to speak to a medical oncologist in particular.
Thank you.
And I'm going to share some of my own experience and also a little bit of literature about liver-directed therapies. Go to the next slide, please. Next slide. Yeah. Basically, when you look at the management options for HCC, multiple factors we need to consider, like tumor related, depending on the size, stage, location, etc., and all that. Then patient related factors which affect the management is age, performance status, and comorbidities, previous treatment. And then liver function is important because treatment depends on the liver functioning liver, especially Child-Pugh score and portal hypertension, background cirrhosis, etc. And then treatment-related factors which will alter or influence the treatment pattern will be on multimodality treatment availability. Then depends on high volume centers where a lot of patients are treated, availability of transplant facility, radiotherapy techniques, and finally the cost. So considering all that, we have to look at BCLC system and also Child-Pugh score for managing this. Next one. Next slide, please. Yeah, we just depend on the BCLC staging for assessment and also for treatment planning. So stage 0 with Child-Pugh A considered for single HCC with normal portal pressure. Then you go for resection and transplants. Then smaller tumors less than 3 centimeter and less than 3 nodules, they go for ablative of RFA or they select the patient for TACE or sorafenib or any other alternative drugs. So many drugs are now available, including immunotherapy. But then this is the general principles on which the treatment depends. So next one. So this is actually a classification from Indian INSALAS called as Puri guidelines. The recommendations are almost similar, but early stage they go for either transplant or ablation, depending on the availability of the facilities like transplantation. And resection is also considered. Smaller tumors, we go for mostly ablation. And then intermediate stage, TACE or TARE. And advanced stage, when there is a portal invasion and extrahepatic spread, systemic therapy is recommended. But then here in this stage, we are actually doing radioembolization to downstage the disease, which is quite effectively done. And later stages, again, transplant criteria, sometimes even outside the transplant criteria, in centers where transplant is feasible, they go for transplant. So next one. Yeah, See, the general considerations when we look at is the resection and liver transplant are supposed to be the curative, and all other methods are actually like RF ablation, cryo, TACE, CERT with Y90, I-131, lutetium. All these are considered as palliative methods, and in combination treatment with TACE and systemic chemotherapy like sorafenib or immunotherapy is actually giving a better response as of now. Next one. We'll just move on to the simpler methods like RF ablation, where we are inducing thermal damage to the tissue through electromagnetic energy deposition. And I don't have to go into more details about the technicalities or physics of RF. Can you go to the next one? Yeah, the thermal damage is dependent on tissue temperature, and the temperature is maintained above 100 degrees centigrade for 4 to 6 minutes. That is how we are able to practically cure smaller tumors. And typically generators deliver 150 to 250 watts of energy, and the temperature rises to 105 degrees centigrade for effective RF ablation. Next one. Next one, please. Yeah, just an example of how RF is being done. This is a patient of 84 years, diagnosed as HCC. And next one. We did a RF. Next one, please. Next slide. Yeah, this is the lesion you can see in the periphery of the liver, suitable for RF. And then that is the placement of the needle within the tumor. And post RF, you can see a larger area of necrosis there. Next. And this patient was followed up. Yeah, next one. Yeah, well, microwave ablation is almost similar, where the tissue is heated, but the energy is from the microwave antenna where the ceramic is placed within the tumor. And the heating occurs due to ionic agitation, just as we find in our microwave instruments. And more useful if the tumor is close to a vessel. When RF is done closer to the vessel, we avoid RF because of heat sink effect. But microwave actually circumvents the problem of heat sink effect. Next one. Next slide. Yeah, this is an example of microwave where there is a small tumor post resection status where partial hepatectomy was done. There was a recurrence. We placed the microwave needle there, and that is the after completion of the ablation. Next one. Next. Yeah, that's another lesion, microwave, and post ablation you can see a large area of necrosis. And after 3 months, that is the appearance of the ablated region. Okay, now we next move on to the TACE. Principle of TACE is that liver has got dual blood supply, and hepatic artery supplies the tumor, and portal vein supplies the normal liver. Chemotherapeutic drug is delivered selectively through the arterial branch supplying the lesion. And also we temporarily block the tumor feeding vessels, that is the embolization. And the normal liver does not suffer from ischemia as it is nourished by the portal vein. This is the basic principle of TACE. Next one. Next slide. Now we have two types of TACE, C-TACE, that is the conventional TACE using doxorubicin with lipiodol. And another is DEP TACE called drug-eluting beads. We use kind of tiny particles which will absorb the drug doxorubicin, and slowly it is released into the tumor so that you have a maximum chemotherapeutic effect. Next one. And TACE is universally and most commonly used technique, suitable for tumors with patients with hepatic reserve, and it should be limited to the liver, and also used as a bridge before transplant or resection. Shown to have benefit even in metastatic tumors. Next one. Next one. Yeah, I personally consider contraindications first, and we consider tumor resectability is the contraindication, because that will be a curative this one, and the TACE will be a palliative method. And we look at the liver functions, bilirubin, albumin, portal vein thrombosis, coagulation profile, everything, before we embark on TACE. Next one. Yeah, this is a patient who presented with a small tumor adjacent to the gallbladder in August 2021, referred for RFA. But since it was adjacent to the gallbladder, we said not really suitable for ablation. So next one. So that's the tumor. You can see the lowermost part of the liver showing the lesion, and that's the gallbladder. So not really suitable for a ablative technique. Next one. So we decided to do a TACE. You see a well-defined tumor in segment 6 of the liver. And super selective catheterization, and then that is the TACE with lipidol, where lipidol is deposited along with the doxorubicin emulsion. Next one, please. Next. Next slide. Yeah. 1 month follow-up shows a good deposition of the lipidol all around within the tumor, and gallbladder is also seen adjacent to that. This would have been a problem if we had used an ablative technique, and we would have damaged the gallbladder wall. So in this particular patient, the TACE was much more preferable. So, and patient is still on follow-up for nearly 4 or 5 years, and no recurrences. Next one. Yeah, this patient actually presented in 2014 with a large tumor in the right lobe of liver here, and we did conventional TACE. Next one. Next one, please. Yeah, this is in 2014 March, deposition of the lipid, and he came back in 2017 with a recurrence almost at the same place. For nearly 3 years, he did not have any issues. He was leading a normal life, and then there were 2 areas of recurrence. Again, we did TACE with lipidol. Next one, please. Next slide. Yeah. Up to 2018, he had almost 6-7 cycles of lipidol TACE. Every year, he would come with a small recurrence. We would address that, and he survived for nearly 7 years. Next one. Yeah, 2020, this was the 8th cycle of TACE for him. 2014 to 2021, 7 years was the survival. And we have been seeing this kind of survival in intermediate stage HCCs, even though there are recurrences, but still we are able to give good quality of life as well as good longevity. Next one. The other one is called as DEP TACE, or drug-eluting beads TACE, where you load doxorubicin onto the tiny particles like this, which will hold the drug, and we inject that into the tumor feeding vessel, and the drug is released very slowly over a period of 72 hours. So the toxicity of the drug will be minimized, and post-taste syndrome is minimized. Next one. And next slide. Yeah, this is how the depth taste results appear. This is a large tumor in the segment 6 of the liver. Post-depth taste, you can see complete necrosis with small air bubbles within that. In fact, the entire tumor is necrosed. So we follow up these patients, and if there is a recurrence down the line after 3 or 6 months, we treat them again with depth test or conventional tests, depending on the appearance and number of nodules. Next. Our analysis of depth test, actually, we had about 33 patients, whereas the complete response was found in 8 patients, and partial response was found in 74% of the patients. And the survival, next one. And this is our own data, where overall survival was 39 months. With depth test, it was only depth test, it was 37 months, and then combined with sorafenib, almost the same, like 39 months or so. It has not really made a major difference between combination of this treatment in our series. Next one. And TARE is another method which we use in patients with advanced HCC where there is a portal vein thrombosis. We can use radioisotopes like yttrium, and we have been pioneering in these isotopes like I-131 and lutetium-177, actinium-277. These are the other isotopes which we generally use. Y90 is one which is universally accepted, and when there is a portal vein thrombosis, most of the tumors are treated. Next one. Next one, please. Yeah, actually, when we are using Y90, which is widely accepted all over the world, in this calculated amount of radiation is delivered by injecting Y90 microspheres through the catheter, almost like in TACE. There's no major difference, but we need to study a lot, like lung shunt fractionation and blocking the hepatic artery branches and short gastric arteries, because there should not be non-target radiation. So to prevent all that, we need to non-hepatic branches have to be blocked. Next one. Next one. Yeah, this is one example where there is a large tumor in the right lobe of the liver, and 3 months after Y90 and then 6 months after Y90, you can see the entire thing has become atrophic and completely cleared of HCC. Next one. We have been doing lipidol I-131 TARE, and what we do is combine lipidol, which is commercially available, and I-131 molecule is inserted into the lipidol. And lipidol I-131 actually gives both beta and gamma photons. So isolation is required for 5 days. And average calculated dose delivered is about 23.8 grays in each of these tumors. Next one. Next one. Yeah, this is what we have been doing, and we use radioactive lipidol, just like the TACE procedure only, and we take adequate radiation protection for the patient as well as the operator. Next one. And 50 millicuries is generally injected, single stage procedure. And we have seen no effect on the thyroid gland, And majority of the patients we have is total vein thrombosis. So, are refractory to other modalities of treatment, and we have been doing I-131 lipidol for these patients. Next one. Apart from this, we also have been doing, this is one example of I-131 lipidol where there's a large tumor in the segment 4 and left lobe of liver with portal vein thrombosis. We did I-131 lipidol. Next one. Next. Yeah, can you run this? Yeah, that's a tumor here with the blood supply and so super selective catheterization here. Okay, go ahead with the next one. Yeah, that's the tumor circulation, which is shown on angio. Okay, next. This was done in November 23, and this is after completion of the delivery of the isotope. Next. Yeah. After 1 year, January 14, this was the follow-up where it was showing good deposition of the lipidol, like in TACE, and then after 2 years, the whole thing has completely reduced in size and completely necrotic, no activity of the tumor. This patient actually lived for more than 3 years. Next one. Next. Yeah, up to 2016, there were no evidence of HCC, and he was doing well. That is the latest picture. But he developed a bladder tumor, papilloma, and then he was operated. After that, we lost the follow-up. Next one. Now we just move on to a few slides of combined therapies. So it is necessary nowadays to integrate the local, regional, and systemic approaches so to get a better response. Multiple trials are available right now using TACE with sorafenib, lenvatinib, immunotherapy are already available. A few of them are we are going to discuss. Next one. This is Emerald 1 trial, phase 3 randomized trial with and without durvalumab and bevacizumab. Okay, next one. So in that, there were 616 patients with stage A, stage B, and stage C HCCs, and they had randomized with double drug combination with TACE, durvalumab with TACE, and then only TACE. So equal number of patients were divided. Next one. And with dual drug and TACE, overall survival was 43.6%. Time to progression was 22 months. Durvalumab with TACE 11.5 months, and only TACE was 10 months. So there was definitely a better response with dual drugs and TACE. This is the conclusion. Next, median progression-free survival was around 10 months. This is LEAP 012, again, combination with lenvatinib plus pembrolizumab, intermediate stage HCC, and along with TACE with the drug and without drug. Okay. Next one. The results were actually showing reduced risk of disease progression or death by 34% in LEAP 1-2, and median progression-free survival was 14.6 months, and 10 months for TACE alone. Okay. Next one. Again, chemoembolization as first line of treatment for advanced HCC, phase 3. Launch trial that was from China. Next one. Next one. Yeah, again, this is recurrent advanced HCC after surgery. In fact, these were quite advanced cases where in 12th center of China, they had combined with lenvatinib 20s and lenvatinib alone. Next. So the endpoint was primary overall survival and progression-free survival. Next one. Overall survival was about 11.5 months in lenvatinib alone and 17.8, 10.6 and 6.4 months in median progression-free interval, and ORR was 54 and 25%. I think next one. I'm coming to the conclusion. Combination therapies show better survival rates as of now. A regional treatment in selected cases give excellent response, but you have to have a very keen follow-up of these patients. Medical management alone may not be sufficient for disease control and survival benefit, but carefully, if we are able to combine the therapies, I think we'll be doing better. Thank you.
Thank you, sir. Thank you for your wonderful presentation and the practical examples of taste, tear, and RFA and this microablation. So, how to decide between RFA and microablation? Which procedure you choose, sir? I mean, any criteria is there? RFA versus
Yeah, if the lesion is peripheral away from the vessels and less than just about 3 centimeter or so, we can go for RF. But for microwave, what we consider is, of course, the same this one is applied. But if the lesion is closer to a vessel or bile duct, we would prefer to go for microwave rather than RF. Criteria will be almost similar, but we avoid RF when there is a nearby vessel.
and this tear will be done when the portal vein thrombosis is there.
Yes, mainly portal vein thrombosis, either single branch thrombosis or right or left portal vein thrombosis. Most of these patients we go for radioembolization. Nowadays,
So
we are doing mainly FAPI with lutetium 177.
that is tear therapy.
Yeah.
So thank you, sir. Yes, definitely, the local regional and the systemic combination is a definite the treatment forward we are doing for most of the patients in our clinical practice. I think more to come in our panel discussion. I would like to request you to stay till the end to participate in panel discussion also. So we will come back to Dr. Vaishnavi once again. Please go ahead, madam. Sponsored session by AstraZeneca.
Sorry, I'll start right away because there was some issue with my network. I'll just share the screen. So is it visible? Yes.
Yeah. To put it in full screen mode, I think.
Okay. Yeah, I'm doing it. I'll stay brief because we have already lost time. So as we were just talking about liver hepatocellular carcinoma is contributing to worldwide mortality and morbidity and cancer-related deaths. And this is because about half of patients present when it is already metastasized to lymph nodes and other organs. Hence, the prognosis is poor in these patients. As far as India is concerned, it is the incidence is increasing, and we see HCC in cirrhotics in India about 1.6% per year, and more than 50% of patients present in advanced stage, that is BCLC and D. The pathogenetic mechanism, the mechanisms which are involved in HCC development are key contributors as far as etiology is concerned, is NASH or viral etiology, HBV and HCV and chronic alcohol abuse. All this lead to cellular stress, and newer mechanisms for HCC development, which have been discovered, are multiple mechanisms in immune escape and evasion. So deregulated liver immune network is what has been proposed as theory for development of HCC in pre-existing liver disease patients. Two important mechanisms like overexpression of CTLA4 and PD-L1 have been noted in these patients, which have been exploited in the drug development. As far as India is concerned, the most common etiology in development of HCC is not viral or alcohol. It is non-alcoholic liver disease. So this etiology should be kept in mind in choosing the right drug for these patients. So coming to management of advanced HCC, I won't go into the earlier stages. As far as advanced stage is concerned, with adequate systemic treatment, we're not going beyond 2 or 2.5 years in these patients. So there is a huge need for newer drug development. And as far as the evolution of systemic treatment is concerned, 2007 was the first drug, which is the sorafenib, which was approved in liver cancer or hepatocellular carcinoma. This remained as the single drug for almost a decade or more until 2018, when we had lenvatinib. Some other drugs had some clinical activity but not very effective, like pembrolizumab, cabozantinib, ramucirumab, etc. However, in 2020, we had the first immunocombination, that is the atezolizumab plus bevacizumab, which showed good activity in unresectable HCC. And now we have two other combinations with IO combinations, which have been shown clinical activity and efficacy in this subset of patients. So the first study was the SHARP study, which we all studied during our super specialty days for my oncology. SHARP trial was the first trial, sorafenib versus placebo, which showed modest improvement in OS, that is 10.7 months versus 7.9 months. And in the REFLECT trial, the lenvatinib versus sorafenib showed 13.6 months versus 12.3 months. But this was associated with significant side effect profile like hand-foot syndrome, mucositis, which was slightly favorable in the lenvatinib patients whom we used lenvatinib. So, but this modest improvement in overall survival and considerable side effects. With these oral TKIs, there was a huge unmet need for better drugs in this space. So that is how the immune checkpoint inhibitors came into play. The first combination which was evaluated is the IM-BRAVE study, which is a phase 3 trial evaluating atezolizumab plus bevacizumab versus sorafenib, the standard of care, in first-line advanced unresectable HCC. The endpoints were OS and IRF assessed PFS in this subgroup. If you can see here, there was good separation of curves in PFS as well as OS, with a good impressive OS of 19.2 months versus 13.4 months, with HR hazard ratio of 0.66 and a significant p-value. So this was for some time the only drug combination which was available for HCC beyond the TKIs. But if you see the subgroup analysis of this combination, if you have three etiologies like hepatitis B, C, if you see hepatitis B and hepatitis C positive patients, there is a good hazard ratio of 0.51 and 0.43 respectively. But whereas in non-viral etiology, which is most common, it did not show significant improvement in the overall survival as far as the non-viral subgroup is concerned. So as we know, the side effects were hypertension and proteinuria, and also this hesitation to use in patients with varices and also thrombosis. These were the few limitations of this combination when we use in HCC. So coming to the new drugs on the block, that is dual immune checkpoint inhibition, IO plus IO. So why was this combination arrived at? So the rationale behind this is, if you see anti-CTLA4 acts on the lymphoid compartment to increase the number of T-reactive cells, whereas anti-PD-L1 acts in the tumor microenvironment to prevent T cell inhibition. So together they have an enhanced synergistic activity against HCC or other cancers. So what CTLA-4 does is this is very important, interesting. Here it acts by it's a regulator of T cell activation in the lymph nodes following antigen presentation. So tremelimumab blocks CTLA-4 and allows T cell activation, whereas downstream we have PD-L1, which induces T cell exhaustion in the tumor. So this is in the tumor microenvironment. So durvalumab blocks PD-L1 and reverses T cell exhaustion. So one anti-CTLA-4 allows T cell activation, and durvalumab or anti-PD-L1 reverses T cell exhaustion. So this combination was tried in non-small cell lung cancer and also in melanoma. After this it showed good activity. I mean, as in melanoma we have EP plus nivo, this combination of anti-CTLA-4 and PD-L1 and PD-1. So this was a combination which was tried in hepatocellular carcinoma. So could we use a single priming dose of tremelimumab with durvalumab to improve the immune-mediated clinical activity? So this was tested and evaluated first in the phase 2 study, 2022 trial, where tremelimumab plus or minus durvalumab in unresectable HCC, including the STRIDE regimen, was evaluated. So the endpoint here was safety alone. Secondary endpoints were OS, PFS, and others. So here they checked both. If you see the part 3, if you see, they checked durvalumab alone, tremelimumab alone, and STRIDE regimen, and a lower dose of tremelimumab with, that is 75 mg with durvalumab. So what did they conclude? So when they also assessed along with safety the overall survival, they got an impressive 18.7 months here, and a median OS with the STRIDE regimen. STRIDE regimen be given 4 weekly. So this median OS was about 3.6 months longer than all other treatment arms. So, and also it did not show any new safety signals in this study group. So encouraged by this phase 3 trial, or the Himalaya trial, came up, which is a multi-center study of tremelimumab and durvalumab as first-line therapy in patients with unresectable. Inclusion was BCLC stage B and C unresectable HCC with no prior systemic therapy. They classically included child to A patients with good performance status. There were actually 4 arms, but the 4th enrollment. So the STRIDE regimen, as I explained before, tremelimumab 300 mg single dose plus durvalumab 4 weekly 1500 mg is what was named as the STRIDE regimen, compared to durvalumab alone versus the arm C, which is sorafenib 400 mg BD. So primary endpoint was OS. If you see here, this was the drug dosing, and so both the combinations were checked. Both combination of 75 mg and 300 mg was checked in this study. As far as demographics and baseline characteristics, these were quite matched. And if you see viral etiology also, all the 3 groups had almost equal distribution of HBV, HCV, and non-viral etiology. And most patients were in BCLC-C staging. And as far as child-2 classification is concerned, 99% of these patients were in child-2A. And they're also stratified based on the AFP levels, less than 400 and more than 400. So coming to the results, there was separation of curves after around 80 months with the patients who received STRIDE had 22% lesser death risk compared to patients who received sorafenib. And the first study to have a longer survival rate, about 3 years, 30.7 months versus 20.2 months, to 30.7% versus 20%. So when they compared STRIDE and sorafenib, median OS of 16.4 months versus 13.8 months was with a hazard ratio of 0.78. So here, STRIDE was not actually powered to compare with durvalumab, but durvalumab again was compared with sorafenib, and they concluded it was non-inferior. So if you see the subset analysis here, HCV, HBV, and HCV, and the non-viral subgroup, the non-viral subgroup has this was 0.74 hazard ratio, and B also was 0.64 here. And also those who had AFP higher levels also performed better in this subgroup analysis. So median duration of response was around 22.34 months versus 18.43 in sorafenib arm. As far as the adverse effects are concerned, it was well tolerated compared to sorafenib. Whoever has used sorafenib, were not able to use in the full dose, we all know. But this treatment-related adverse events were seen compared between the STRIDE and sorafenib. It was comparable and is quite safe here. Most common side effect of STRIDE regimen, treatment-related side, was rash, pruritus, and diarrhea. So there was the treatment-related hepatic or hemorrhage events. Grade 3 was noted in around 0.5 or 2 patients alone in the STRIDE regimen. Esophageal-related variceal bleed was not seen in these patients. Hence, NCCN has included this regimen, tremelimumab plus durvalumab, with a single dose of tremelimumab, as the first-line systemic therapy of preferred regimens in unresectable hepatocellular carcinoma. So to conclude, it's the topmost common cancers, one of the topmost common cancers in HCC. There is a shift in the etiology also as far as India is concerned. There is a shift from viral to non-viral etiology. So more and more drugs in this space will make some change and be a game changer. And immunotherapy combination have shown better anti-tumor activity than TKI alone. And a new standard of care has been atezolizumab and bevacizumab till now. STRIDE regimen with improved OS versus sorafenib demonstrated a 3-year OS rate, and it seems to benefit across subgroups, including the non-viral. It's not that it fares better in non-viral, but including the non-viral patient population, and it's well tolerated, lower rates of discontinuation, and especially hemorrhage, which is always at the back of our mind using the immunodrugs and TKIs and also bevacizumab combination. So and durvalumab monotherapy also represent potential new treatment options. Thank you.
Thank you, Dr. Vaishnavi. I think very good presentation. So definitely this treatment of hepatocellular carcinoma has come a long way, starting from sorafenib. So how do you choose? I mean, these two options are there now. The targeted therapy, I mean, bevacizumab plus atezolizumab versus this STRIDE regimen. So, any practical experience you have, clinical experience you have with this combination,
Yes.
or yeah.
With this STRIDE, yes, sir, we have used it on 5 patients actually, as all 3 sub-centers included. Yes, it's easier to deliver. We don't see any major, safety signals or safety problems. But yeah, long term, we also need some experience till we, very confidently say this is better, that is better. But as you asked, how to choose, I think 2 factors. One is what is the etiology, if it's a viral etiology. Although these studies were not designed to say this works better in this etiology. However, viral etiology or non-viral etiology would be one factor to consider atezolizumab, bevacizumab versus the STRIDE regimen. And second, if patients have active bleed or huge varices, you're scared to use bevacizumab. That is one scenario where this works very well. And also thrombosis, although we know it's not a standard, it's not an absolute contraindication to use bevacizumab. I think with equivalent data, efficacy data, this would be a good regimen to use in those patients if, there are no cost issues.
I think when more and more options are available, we have to go as per the side effect profile. So that is what. And viral and non-viral in both
Yes.
the groups, it is not pre-planned subgroup
Yes.
analysis. It is the
It's
post-planned
not clear.
subgroup analysis. So we
Yes.
cannot decide on that. And definitely,
Yes,
like
exactly.
in CML and other CL lung, so many TKs are available. So we choose according to the side effect profile of the drug. So here also we have to choose according to side effect profile of the drug. Given there is no head-to-head comparison of these two combination. So I think more to come up in our panel discussion. I request you to stay till the end for the panel discussion. You may have to enlighten us more that. So we'll move on to our next sponsored session by Dr. Ravi Tippeswamy. I think we are a little bit lagging behind. I think over to Dr. Ravi Tippeswamy for your talk on reproducible safety and efficacy of atezolizumab bevacizumab combination in HCC. Results of the AB real study. So please over to Dr. Ravi Tippeswamy.
Yeah. Thank you, Srinivas, and I thank for giving this opportunity. Let me just load my screen.
Sir, you want us to share screen from our end?
I think it is here. It is visible, no?
Yeah, sir, just make it full screen. Yeah.
And I thank Roche also for giving this opportunity. So we'll just discuss the real world evidence for tezobev in unresectable HCC. So I will briefly go on to the main points as this already has been discussed. Whenever we plan for management in advanced HCC, mainly this BCLC staging and child staging helps. We know that as it is been discussed with the previous speakers, lot of options are available. And basically where our patient fits into, whether it is in intermediate or advanced, because early the intent is curative, intermediate will downstage the disease and make them, intent is curative, but in advanced it is only control and giving good quality of life with longer survival. And these are the latest phase 3 trials in advanced SCC. And as Dr. Indushekar sir also has described, now this systemic therapy has moved into the earlier, even in local and local regionally advanced stages. Coming to the topic of importance today, this IMBREV study, we can clearly see here, as now we have got two good regimens, which one to choose. So this IMBREV study included the unresectable HCC. It was in the first line, BCLC B and C with good liver function as child puts A. And this is one important, patients with main portal vein thrombosis, it was included. They were randomized between the standard arm and the experimental arm. At that time, the standard arm was sorafenib and atezolizumab was the experimental arm. We can clearly see here the responses, the primary endpoint, that is overall survival, and the co-primary endpoint PFS, and the objective response rates. Clearly, the curves start separating very early, and there is no overlap in the curves. And we can see the hazard ratio. So the hazard ratio is very good.
Dr. Ravi,
So,
just requesting you to on your video camera.
yes. So now, since we have got two IO combinations in the first line, how to choose between? So as Dr. Srinivas was telling, it is based on mainly the patient characteristics and the tumor characteristics. But by large, the principles should be the first line systemic therapy should widely benefit of our patients. It should be less toxic. The regimen should have high response rates, and it should give long PFS and overall survival. So here we can see when we are using the atezolizumab combination, how it is different from other regimens. The curve starts separating very early. So by the end of 2 months only, we are seeing here the benefit. And that means the objective response rate of this drug is very good. And this will give a meaningful benefit for the patient, because as oncologist, we will be looking mainly at the survival curves. But for the patient, symptom relief is very important. And this regimen ticks that box. That is, it has got good symptom relief because of good objective response rates. And we can see here regarding the other studies, if we see the IPNIVO and if we see the STRIDE regimen, we can see in the IPNIVO, the curve start separating only later point, and there is some crossover at about 1 year, which again suggests that initially the magnitude of benefit is not that great. It is only in the later part we are seeing the magnitude of benefit. And coming to the STRIDE regimen, again we can see here until around 6 months, the curves are not separating. Again, looking from the patient point of view, getting an early objective response rates. So atezolizumab ticks that box. So even the literature review on various meta-analysis of the regimens available, where atezolizumab has been compared with TKIs, it has been compared with IO. We can clearly see that almost all the meta-analysis suggest that the hazard ratio for this drug is very good, and it is a time-tested drug. Coming to the responder analysis, as we see in any immunotherapy, those who respond, the responses remain very durable. That is, the depth of response is very good. We can see here the 4-month landmark and 6-month landmark analysis. And when we continue to follow, those who have got good responses, they do well for a long period of time. And water plot curves again suggest that the depth of response for this drug is very good. Coming to the duration of response, it is 18 months versus 14 months. So there are mainly 3 factors which are important for long-term survival. One is the response rates, the other is the depth of response, and the third is the longevity of response. Atezolizumab satisfies all the 3 factors. So what about in patients with varices? So even in patients with varices, we can clearly see that atezolizumab demonstrated efficacy over sorafenib. Though we should not have cross trial comparison when we compare this regimen versus the other regimens where varices was included as a very important factor in deciding the treatment, there were no important subgroup analysis. In IMBRAVE study, it clearly shows that those patients who had varices and those patients who didn't have varices, the benefit was similar, which again gives us confidence that even in real world practice, this is a doable regimen. And if we see the bleeding events, because here we are worried mainly about bevacizumab, the majority of bleeding events were grade 1 and 2. This has been discussed with the availability of STRIDE regimens. Does the etiology matter? So as it was discussed by our earlier speaker and by Dr. Srinivas, though they're all subgroup analysis, they are not powered to see that the etiology matters. And atezolizumab has time tested and it has clearly shown that even in viral etiology and non-viral etiology, the benefit is similar. So the IMBRAVE 150 clearly shows that irrespective of etiologies, this can be a first-line regimen. And we get the overall survival benefit in viral as well as non-viral etiology HCC. And we can see the survival curves also. Clearly, there is no difference in the survival. So does etiology really matters in the present scenario? Definitely no, because they are all subgroup analysis. Atezobev and Straits regimen both can be used irrespective of the etiology. And if we see the data of Atezobev, where the initial objective response rate is good, the duration of response, once they start responding, it is longer. So we will get the early benefit. So in the systemic review and meta-analysis, there was no significant difference of overall survival between non-viral and viral etiologies. And clearly, we can see here the benefit is good in both the etiologies. So coming to the real-world experience, so Atezobev was the first combination which came into the clinical practice. And if we see the large number of real-world studies from US, Europe, and Asia, it was analyzed in this AB real study with the primary endpoint of PFS and OS. This study again gives us confidence. Look at the curves, the overall survival, it matches the clinical trial. And the PFS also matches the clinical trial. So with the overall survival of around 16 months and the PFS of around 7 months. So this Atezobev combination, even in real world evidence also, it is matching with the original trial. So this is one more real world study from Taiwan, which again shows that the OS benefit is similar to what it is in the original IMBRAVE study. So coming to this VP4 patients. So what is VP4 means? It depends on the site of thrombus. Generally, it is a very poor prognostic marker. But if we see this Atezobev data, that is IMBRAVE study, clearly shows that even in this VP4 subgroup of population where the thrombus is in the main portal vein, there also the benefit is significant with OS maintained. So many of our patients in our practice, what we see is they skip the doses because of various reasons, logistics or cost. In those kind of patients, does the outcome matters? Again, the real world study, it has been shown that in patients who have skipped the doses due to adverse events, there was no significant impact on the survival, that is OS and PFS. So the quality of life is very important, and post-progression treatment, whether the patient is fit enough, that is also important. If you see the patients who have received the Atezobev combination, the quality of life and the liver quality is very well maintained. So they will be eligible for the next line of treatment. So this is one more important point while considering the Atezobev combination. So to conclude, what we can say between the two regimens, though we should not cross compare the two regimens, both the regimens are good, but clearly we should not say divide our patients based on which combination to give presently based on the etiology, especially viral and non-viral. Atezobev, as I discussed, it has got good objective response rates. And if we see the initial suppression of the curves, there is no crossover, and the wider suppression of the curves. And those who have responded, say the depth of response is very good. And as I showed in the water plot curves, the depth of response translates into the long-term benefit. So considering all these, even with the available of multiple regimens, that is IO regimens or IO-TK regimens, probably it may come in the future, Atezobev still should be one of the armamentarium in our management of unresectable HCC. So with this, I'll conclude. Thank you.
Yeah, thanks, Dr. Ravi. I think this is the good platform for our next sponsored panelist discussion by Dr. Roche. I think I will call upon our esteemed panelist, Dr. Mansi from Sparsh Hospital, Dr. Satish, HCG Bangalore, Dr. Vishwanath from Apollo Hospital. I think all are available. I hope my slides are visible, I think, no?
Yes, sir.
Yeah, sir.
Yeah. So, yeah. Dr. Satish, Dr. Vishwanath, Dr. Mansi.
Yes, sir.
Yeah.
Yes, Srinivas, we are.
So, yeah. Shall we go ahead?
Yeah, I can
I
start.
think we already had the points of discussion for this management of hepatocellular carcinoma. Especially two regimens are available now in frontline management of metastatic hepatocellular carcinoma, both atezolizumab, bevacizumab combination, as well as the durvalumab and tremelimumab combination. So this is a 53-year-old male with complaints of abdominal discomfort, distension, loss of weight, and loss of appetite. HbA1c was reactive, and this alpha fetoprotein was 4.59. So scan suggestive of liver lesion plus abdominal plus mediastinal lesions. So biopsy was suggestive of hepatocellular carcinoma. PDL1 was 35%. And the patient is, I think, a child book score of 7. So I think he will come in the grade of metastatic HCC with child book A scoring. So these are the lesions with HCC with extensive nodal metastasis. So this is the first pre-therapy lesion, and this is the post-therapy lesion after 6 doses of atezolizumab plus and bevacizumab combination. Increased necrosis and reduction in the arterioportal enhancement.
Hello,
So even
Dr. Srinivasa.
yeah.
Yeah, just to inform you that Dr. Poonam Patel is also the panelist for this discussion, and she will present the case after. Sir, you are on mute.
Okay. Thought she is the presenter for next case. That's why I thought she
Yeah,
is not.
yeah.
Sorry, madam. I think we will include discussion with you also.
No problem.
Yeah. So after this therapy, there are significant regression in the nodal disease as well, and resolution of ascites. So I think who are the right patients for cancer? 5O combination in unresectable HCC. Dr. Satish.
Hello. Yeah.
Yeah.
See, I'll try to consider IO therapy in all the cases. Only thing is which regimen, unless it is a child book. This is a B7. Still we can we'll try to see that is what you have presented this case. Child book A and B7 we'll try to consider. If the patient performance rate is not good, then I may not maybe I try to go symptomatic, or maybe I try to go for a symptomatic treatment to be there. And if in general condition, because if the etiology is viral etiology there, altered left is there, I may take a gastroenterologist opinion, medical gastroenterologist opinion, try to stabilize the patient. If patient becomes stabilized, I might try to reconsider for opting for the treatment. This is a very tricky situation. But all the patient are trying to consider, but only thing is which combination to choose. See, IO combination, see, one eligibility for the bevacizumab. Any contraindication of bevacizumab, that's one thing try to see the day one. And we have to evaluate with the endoscopy any risk of vessel bleeding. The banding other thing try to do it. The another thing is their underlying etiology, but etiology is not a criteria to take a decision. We'll see that now the cost is also one of the factor in our day-to-day practice. I try to see the high burden of disease there. I might try to go with the IO versus MAB, that is atezolizumab versus MAB. With a low burden disease there, non-viral etiology that if sometimes I may not able to give a versus MAB. There I try to see IO combination that Druva-tremelimumab combination. I try to use it.
Okay. Dr. Mansi, so you also look into this etiology before choosing the options of IO versus IO and bevacizumab combination?
Yeah, so like Dr. Satish said, I also check what is the etiology, but definitely I'm more comfortable with atezo-bev because we've been using it for a long time. So unless there is absolute contraindication for that, I don't look for the other combination. Slowly, I'm sure we're all going to adopt it much better, and we'll be more confident about the newer combination as well.
Yeah, Dr. Vishwanath?
Yeah, I agree with the other panelists. Just that I would like to add that I would get an endoscopy done, and if there are no varices, irrespective of the etiology, I would consider atezo-bev because the follow-up exploratory analysis of the IMRAV 150 showed that even for non-viral etiologies, there was equivalent responses. And similarly, the tremelimumab and durvalumab, the STRIDE regimen, they excluded VP4 patients. So in patients with VP4, I would probably use the atezo-bev combination.
Yeah, I think Dr. Poonam, madam.
Whatever has been said, I think they've covered everything.
Yeah. So I think definitely, though there are a discussion more about etiology and varices is concerned, more discussion about whether we should use this, but still most of these etiology concerned subgroups are not pre-planned one. I think they are the post hoc subgroup analysis. And I think yes, more commonly we are seeing NASH induced HCC, and I think we should more data to come in, I think, before deciding whether we should use IO more in non-viral or viral. I think either head-to-head comparison is not there. We can give either of this combination. And as Dr. Vishwanath has told, there are more data has come up in atezolizumab and bevacizumab combination. More long-term statistical studies are there, and worldwide more studies are there. I think we are comfortable as of now with this combination. So I think definitely hepatocellular carcinoma is a multidisciplinary team discussion, as we have doing this in many of our patients, including interventional radiologist, gastroenterologist, and pathologist. And local regional therapy is definitely required, especially local advanced where there are non-metastatic, where even the local regional therapy, either TACE, TARE, followed by this IO plus bevacizumab combination is one of the treatment of choice. So, since there are limited first-line treatment options available, how do clinicians make best decision for patients to improve survival? So, Dr. Mansi, I think we have discussed. Anything you want to add up?
Yeah, so involving the medical gastroenterologist, the palliative team, everybody to improve the quality of life of the patient is one thing which we should consider. And besides that, I think about the combinations we've all already discussed, so nothing more to add to that.
Okay. So, changing the natural history of advanced hepatocellular carcinoma, when do you start your systemic therapy. Just a minute. So, do you start systemic therapy, whether BCLC-B stage, BCLC-C, whether TACE, TARE, followed by PD-L1 inhibitors? Dr. Satish? I think we have discussed this, I think, most probably. PD-L1, I mean, you want to do PD-L1 status before considering, immunotherapy is required or not, whether that is also one of the factor to consider immunotherapy or IO combination, IO plus bevacizumab.
I
Dr.
don't.
Satish?
I don't do at all. PDL1 I don't consider at all. See, the only thing that the option like we had discussed previously, that what are these two combinations? Sometimes we may go with a single agent with a limontinib also. Sometimes they may not be even fit for a contraindication for IO also is there. We may not even opt for even IO therapy also. There we may opt for only single agent limontinib. Then another thing is we may try to involve a multidisciplinary team. We may use some local advanced, either we may use a TACE or TARE, or sometimes SBRT also we try to use. Sometimes portal vein thrombosis we may use a radiation to the portal vein thrombosis that try to help the patient to improve the condition. These are things we try to explore along with the involvement of the hepatologist and try to improve the liver function and stabilizing and maintaining during the course of anti-cancer. These are things will help us. But PDL1, unless is a try to have a part of some clinical research or study, I may do it. Otherwise, I don't do at all.
Okay. Dr. Vishwanath, this radiation oncologist, this SBRT, in your practice, you want to involve along with whenever the portal vein thrombosis. We do here HCG is focused the radiation to the portal vein thrombosis so that it may open up. And so, any concept there? You also practice there?
Yeah, so I would like to throw some insights over this BCLC-B because now the entire paradigm is changing. And we know that there is this ABC, so you give Atezolbev followed by some TACE and then go for curative resection. All these things are changing, and the role of systemic therapy is coming more and more in the intermediate stage or the BCLC-B. And I think in this intermediate stage, there are again like local directed therapies. I think SBRT, though mainly indicated for early, but there are situations where we also consider SBRT for BCLC-B. But I don't have much experience though in this. I've not referred any patient for radiation for SBRT in this particular situation.
Okay, so these are the demographics across recent first-line studies. So we can see here. So most of the patients will represent what we see in our real clinical practice. Either the BCL B or C patients are more common, and child pug A and B are more common. B7 is less, but we do see more of B, child pug B and C more common in our clinical practice. Hepatitis B, hepatitis C, and non-viral are equally represented. Macrovascular invasion and extrahepatic spreads are either of the combination is also represented, and most of the patients had more than 200 also, as well as more than 400 patients. So, Madam, Dr. Poonam, Madam, how do these demographics? So, you see typical population what we have seen in our this IM Brave study in the first line setting.
Yes, so we do see all sorts of patients. Most of them are associated with fatty liver disease, and many times they come in advanced disease and poor performance status. And I don't think so. Most of our patients may fit into these classic criteria which they took in the clinical trials. We do offer them the therapies because we don't have anything else. And even though such cases were not included in the trials in real world scenario, they do well. The patients do well, even if they were not classically fitting into the clinical trial criteria.
Yeah. So definitely, most of our patients doesn't fit into child pug A or only BCLCA, most of them will either the Child-Pugh B or C, or the BCLA staging B and C, and most of them will be advanced disease. VP4 studies, VP4 segment disease will be more commonest. That is what in our clinical practice, and VP4 is well represented in this IMBRAVE 150 study. So I think already Dr. Ravi has told about this IMBRAVE study. VEGF and immunotherapy, VEGF, anti-VEGF and immunotherapy combination. VEGF immunosuppression is reversed by anti-VEGF and promote T cell infiltration. Dr. Mansi, you want to comment on this? The combination of IO and VEGF, anti-VEGF combination, synergistic, how it is synergistic. Do you agree with this? Dr. Satish, I think Mansi is... Hello?
Yeah, so there's some lag in my network. Yeah, I completely agree, sir. So definitely there is a synergistic effect, and we do see it working in most of our patients. As compared to one of them being used alone, the combination is definitely much more effective.
Okay. Yeah, I think this is what it is. Macrovisual invasion and extrahepatic spread, and baseline AFP either for more than 400 or more than 200 were well represented in this study. And so IMBRAVE study also included patients with prior TACE treatment. So prior TACE treatment were there in almost 39%, and in the sorafenib arm around 42% of the group. And this is the, I think, how many days do patients receive before being referred to oncologist? Can this data have any impact on the number of days given to patients? Should we start early systemic therapy? I think Dr. Satish will have more knowledge on this. I think he's the best person to get a comment from him, I think. Dr. Satish, sir?
See that like there are patients they have taken a taste even 4, 5 also, that like before coming to the oncologist. See, now the things have changed. Actually, the integrating multidisciplinary treatment, intervention radiology person along with the medical oncology and even hepatologist, integrating that. I was a part of the even this the Emerald 1 study. Combination of that is a taste with Durvalumab and bevacizumab sequence we were giving, monitoring. That only thing is there. See, if we go for a clinical practice taste, they may not give back to back in every 4 weeks. They may do 4 every 8 or even 12 or 12 weekly. They'll do it. But clinical trial as a part of thing we are supposed to do every 4 weekly. They tolerated well what we had that one actually. The only thing is like before we used to see that taste after phase stage only, like they used to come. Now previously we had like maybe 6 months to 1 year we used to use the practice of limatinib along the taste we used to use it. Now that more of it is rather than post Taylor coming, now it will be more of combination therapies will be there. But only thing is affordability of taste with immunotherapy. That is the one of the major challenging for our routine all the patients. Maybe eligibility issue also that we should take in a consideration. Sometimes the taste with linmatinib we can use it. Otherwise, not eligible. I mean, cost is a factor of linmatinib. Otherwise, affordability is not an issue. Eligibility to take immunotherapy and bevacizumab. I try to consider taste with combination therapy. That is the way we have to forward. We have to practice our day to day. But we see that finance is a major challenge in our practice.
Dr. Vishwanath, TACE followed by Druva plus tremelimumab or atezolizumab plus bevacizumab.
Yeah, I think like Dr. Satish mentioned, these combinatorial approaches are the way to go. Pushing systemic therapy to the intermediate stage BCLC, and using either durvalumab and bevacizumab or atezolizumab, and followed by TACE. I mean, TACE followed by this. So, but the only issue is that if you look at the Emerald 1 study, it has only shown PFS benefit. It has not shown OS benefit. So, if you look at it, if you look back at the critics of any of these trial results, that is one thing they would have mentioned. Not critic exactly. So, we are still looking at any OS benefit. So, it's probably early days, and there's only PFS benefit so far.
So, I mean, you want to follow, suppose OS benefit is there, you want to give this Truva Tremi or this atezolizumab, bevacizumab, anything you want to replace?
I think there is data for Bev plus Durva, and Atezo-Bev. There is a trial which has looked at that as well. And then there is this LEAP 012 study where they've looked at Pembro. So that is also shown only PFS benefit. So probably once there's an OS benefit, I think Durva plus Bev or Pembro. I think the Pembro LEAP 012 also showed only PFS benefit. We'll have to look at if there's any OS benefit. Yes, definitely yes.
Yeah, Vishwanath, many of our practice are lung cancer, breast cancer, even CDK4 inhibitor, even osimertinib adjuvant treatment also. They're all come with a PFS benefit. When that follow-up will come, that OS data also will come. Early, you have a first 3 to 5 years, we will have more of benefit of PFS, but you have to have follow-up and to have a OS benefit. But PFS is showing is almost nearing doubling. It's a good thing data. But the toxicity and the feasibility, that is a major challenge that we have to see.
So this is the overall survival benefit, which is a co-primary endpoint, with almost 40% of the patients benefiting with this combination of atezobev and atezobev combination compared to the sorafenib. So one thing is actually in most of the sorafenib trials, either the reflect trial or sharp trial, I think it is 10.2 months, and in this trial it has given sorafenib has given OS of 13.2 months. So I don't know whether most of us we are not using this. Whether you see this in your clinical practice, madam, I think you may be you might have used more of the sorafenib in your clinical practice.
Yeah, initially, yes, we used to use a lot of sorafenib, but then with the side effects, almost all the patients had dose reduction, and we never really found the responses that we saw in the trial. Even in the SHARP trial, the delta was very small.
Okay. Yeah. So in the reflect trial, it was around 13 months, and in the sharp trial, it was 10.2 months. So I think depending upon the experimental arm, the sorafenib also is giving different OS benefit. I think we need to look into it. But most of us, our contemporaries, I think we have less often used, and definitely we have used the sorafenib, and we are not able to reach that 800 mg dose. Most of us around 200 to 400 mg, most of our patients are able to tolerate. So this is the updated overall survival analysis, 19.2 months with hazard ratio of 0.66, almost 40% of the patients benefiting with this. So clearly curves benefit at 6 months, 12 months, and 18 months. There is a separation of curves. So this is the updated response and duration of response. Overall response rate is also more or almost 30% of the patients benefited with this regimen compared to the one under duration of disease control rate is also around 74%. So Dr. Mansi, overall response rate and the disease control rate in HCC, how it is important?
Yeah, so definitely in patients where we want, improvement in the symptoms very briskly, ORR definitely makes a difference. So there have been some patients, I've had, I think, 2 patients who we've used this in an off-label setting where we've given a pre-transplant, and then they've gone on to do a transplant. And the response rates did make a lot of difference in that, because once you get the response, then you take the patient off the atezo and give them a washout period of say 8 to 12 weeks, and then go for transplant. So in patients where we are using it as a bridge, it is important. In patients who are symptomatically suffering a lot, it's important. So I definitely anybody would want ORR to be good.
So
So
symptomatic improvement is required. Definitely, a robust response rate should be there. Yeah, I think we will talk about. I think we have spoken about this very difficult patients where combination of macrovasal invasion with extrahepatic spread. Dr. Satish, thoughts on OS, PFS, and overall response rates. Though it is less compared to though no extrahepatic spread. What is your thoughts on this?
Yeah, being like OS is important for us, but you may not have to have the OS benefit in all the study, because it depends on the which line and the thing, and the next line treatment. There are many deciding factors. See that HCC, definitely we have to have the high burden disease, symptomatic disease. I like to have the response rate is a criteria to symptomatic relief. That time I try to see the combination therapy of atezolizumab and bevacizumab. They try to have a better response rate compared to the IOO therapy. You may not have immediate response, but they have a durable response. They are noted those are responding to double that IOO combination. But the symptomatic immediate the relief and other thing, that the PFS data definitely is good with the combination of anti-VEGF and IO therapy. That's what we have to see. And later the subsequent follow-up, that is also the important thing. The survival data is also important. They require a long-term survival is also important. That's what this is the factor I try to see, that based on the patient factor, what is the immediate need of this one, and even meantime, like I try to see the long-term survival also important.
Yeah, definitely this sorafenib compared to sorafenib and this atezolizumab combination, definitely there is a doubling of the OS and PFS compared to the sorafenib arm. So I think we all know the safety signals, safety data of this atezolizumab combination, definitely more superior compared to the sorafenib in terms of side effect profile. Most of our patients used to come with hand foot syndrome. I think that is not there with this combination. So 15% of the patients discontinued trial. So most important side effects which deter to you to start combination treatment. Dr. Vishwanath?
I think more or less, if you ask me, in my experience, these patients have all tolerated well. I think bleeding, proteinuria, hypertension, these are the main side effects which we have noticed. Atezo has hardly caused any problems in whichever patients have given. It's probably the BEV which has probably caused a lot of proteinuria, maybe hypertension, and maybe a few episodes we have probably had some bleeding, but never to the extent of discontinuing treatment unless the patient selection has been bad. If the patient is more like, say, the child puke is
That would
not great.
see.
Yeah. So only in those situations. But otherwise, I think if you, like Madam said, I think most of our patients have tolerated well.
Yeah. So definitely well said. I think we didn't had any. We didn't discontinue any patients because of the side effect with this atezolizumab combination. I think most of them have well tolerated. So yes, coming on to the important side effect profile, or choosing the patient with esophageal gastric varices. So as per the trial, most of them they have excluded with esophageal varices, or they have treated 6 months before and they have selected the patients. So, Madam, what is your clinical experience? What you do whenever the patients with esophageal varices are there, for especially when you're choosing with this atezo combination?
Yes, like as in the IM-BRAVE trial also, all patients had to undergo upper GI endoscopy, and the variceal banding has to be done before starting the combination. And I was just thinking that we don't have to defend that it's only the PFS. I think in a metastatic disease, even an improved PFS is equally important if the quality of life is well maintained. So that was one comment I had to make for the earlier discussion that was there. And bleeding events after banding, I have not seen any significant bleed for any patient actually.
No, usually in this study they have excluded. I mean, they have taken patients 6 months before. I mean, you do banding and immediately you go with therapy, or you wait for some 1 or 2 months, something like that, madam?
No, it
Immediately we
started
can.
yes,
Yeah.
yes.
Okay. So active bleeding is there. That is what they have
Yes,
excluded.
that is
Active
the
bleeding is
absolute
there. Yeah,
contraindication.
they have
Yes.
excluded the patients, and
Yes.
they have not mentioned whether they have done banding and then went ahead with this one. That is not mentioned. So Dr. Vishwanath, Dr. Satish, Dr. Mansi, I would like to hear from you one statement from on this.
Yeah, I'll try to see that risk of bleeding that is assessed, and post banding definitely I'll consider. Okay. I don't wait for a 6 month or anything. Yeah.
Dr. Vishwanath?
Yeah.
I agree with Dr. Satish.
Okay. Dr. Mansi?
Yeah, completely agree with all of them. Yeah.
So I think these are the forest plot depicting all subgroups were favoring atezolizumab bevacizumab combination, except this non-viral which we were discussing in our previous discussion, whether it is PD-L1 negative or the hepatitis B, hepatitis C, everyone AFP more than 400 or less than 400, all favoring. This is the PFS data and this is the OS data, all favoring the atezolizumab bevacizumab combination. So this is one study just I come across with the meta-analysis of the atezolizumab bevacizumab combination versus lenvatinib or sorafenib in non-viral unresectable HCC, and they have concluded that lenvatinib has to do more with in the management of non-viral related NASH. So more these are the retrospective analysis they have done, and they have seen that lenvatinib involved trials have done very well with the non-viral HCC patients than compared to the viral etiology patients, not even the immunotherapy. So more data need to come, I think, most probably. So this is the conclusion in this study where they concluded that large number of advanced non-viral HCC patients showed the first type treatment with lenvatinib is associated with a significant survival benefit compared to atezolizumab plus bevacizumab, in particular in patients with NASH related HCC or NAFL related HCC. So I think this is the retrospective study. Is very good study. I think you can refer and go through that. So one more meta-analysis. This involved almost 41 study all over the world, real world clinical scenario, real world study. So almost all the studies were favoring this atezolizumab bevacizumab combination, which is I mean and most of them they included the child book B and C were more common than the child book A in the almost most of the studies. So almost 47 studies were there. So just to mention about, I think so guidelines recommend the patient should undergo an EGD within 6 months prior to initiation of therapy. Varices should be treated as per the standard protocol, and grade 3 and 4 bleeding were 6.4% versus 5.8% compared to the sorafenib arm. And so I think we know about the side effect profile. Most of our patients are able to safely go through this combination without much of hepatitis, without much of other endocrine abnormalities or immune mediated abnormalities. So I think final comments from each of our esteemed panelists. Dr. Poonam, madam.
So safety profiles of, I think the slide went away. Which one you had put up? Yeah, sorafenib, now long, so since
Overall,
long I
madam,
have not.
this is the same thing. So overall, about atezolizumab combination.
Okay.
Yeah.
Okay, so I will be presenting a case which I am
We will
treating
go through that,
currently.
madam. Yeah.
So
Dr.
yes,
Satish, Dr. Mansi, Dr. Vishwanath, you want to add anything? Comments? final comments on this combination?
It's definitely more tolerable than sorafenib, so I think we all agree on the safety profile of it being better.
Okay. Okay. Dr. Satish?
Yeah, atezolizumab is easily manageable. I think every one of us used, and I'm very happy. Unless it's a contraindication for use of bevacizumab and IO therapy, I think we are very comfortable. And that's what. And the sorafenib is like I think no one is practicing from almost more than 4 5 years. Everyone is switched over to linvatinib. Sorafenib is very toxic. We used to use it. None of the patient is going for a full dose. Most likely, even though 200 mg BD dose is not even not a tolerable dose. So for our most of our patients.
Apart
As
from
we are,
the side effect profile, role of functioning, physical functioning, quality of life is also well maintained with this combination. I think with this, I will end my panel discussion. Dr. Poonam Patil will present one more case, and we will complete the session after that.
Yeah, thank you very much. I'll not delay. I'll just present this case. Yeah, I hope you can all see the slides.
Yes, madam. Yes.
Okay.
Yeah, ma'am, just make it full screen.
Yeah, I am trying to. Yeah, are you able to see it full screen?
Yeah,
Yeah.
ma'am.
Okay. And the slides are moving as well?
Yeah.
Okay. So this is about a case that is who is currently undergoing treatment. This is my disclaimer. And this is regarding a 70-year-old man who has history of hypertension, hypercholesterolemia, diabetes, and also chronic liver disease for 5 years. Now he presented in April 2023 with some vague abdominal discomfort, and because he also had chronic liver disease, for screening purposes, he underwent an ultrasound of the abdomen and found to have multiple liver lesions, had a biopsy, diagnosed to have multifocal hepatocellular carcinoma in April 2023. This was his PET scan at that time. You can see the liver lesions here. Apart from the liver lesions, he also had a left adrenal nodule, multiple lymph nodes below the diaphragm, and also tumor thrombus in bilateral portal vein, main portal vein, hepatic vein, IVC going to the right atrium. But it was not a complete block. It was a partially canalized vein. The alpha fetoprotein was more than 10,000. He underwent upper GI endoscopy and banding of some small esophageal varices that were there. And in this case, all the treatment options were discussed with the patient and his relatives, and they all agreed to go in for the treatment. I just wanted to take an opinion of the panel that what are the treatment options you would consider. I know some of the questions are a little repeat of what we had in the last panel discussion, but I will just take you fast. So Dr. Mansi, in such a case, what treatment option will you consider first?
Ma'am, there's a tumor thrombus as well, which we again see very commonly. So I would definitely start systemic treatment, and sometimes in such patients we've given some palliative RT also for the tumor thrombus.
Okay.
Yeah, along
So,
with systemic treatment.
okay, I have never used palliative RT because this patient had a long thrombus going from the portal vein to the right atrium. So I really don't know how easy or difficult it would have been. Well, this patient had virus serology negative and Child-Pugh score was A, and he was started on therapy with atezolizumab and bevacizumab from April 2023. So I think I'll not delve on this further because Dr. Indushekar showed us in multiple studies and his practical experience that if we add local regional treatment in addition to systemic therapy, definitely it improves outcomes. So, but for this patient, we had not done any local regional treatment. Dr. Srinivas, would you do a local regional treatment first for this patient before starting therapy? or you think you would
Yeah,
start
it's
first
already
systemic?
systemic disease. So
Huh.
I think we can go ahead with systemic therapy, and once the tumor shrinkage is there, then we can add up the locoregional therapy. And yes, we are telling about the radiation to that portal vein thrombosis. There are some studies where we do practice in our hospital, focused radiation to that portal vein thrombosis, as SBRT, and along with that systemic therapy we do practice.
No,
So that
but
has
like this
given some.
patient had thrombus extending to the atrium. So
I don't know about that one, but only limited to portal vein thrombosis is there. I think
yeah,
we do give. I think otherwise we can use this atezolizumab bevacizumab combination for this upfront as such.
yes. So this patient also was treated with the combination, and after 5 months, he did well. His alpha fetoprotein, which was more than 10,000, came to 100, and PET scan showed all disease sites reduced in size and metabolic activity, as you can see in this PET scan done 5 months later. So this patient was continued on atezolizumab and bevacizumab. For the adverse events were occasional fatigue and weakness. In November 2024, he developed ascites, which was transudative in nature and attributed to his chronic liver disease status. Cytology was negative for malignancy, and alpha fetoprotein was absolutely normal. And in this last 2 years of his journey of chronic liver disease and HCC, he has undergone therapeutic ascitic cap 2 times. PET CT scan done in February 2025 revealed increase in one liver lesion, but all the other sites of disease, including the portal vein thrombosis, adrenal and nodal lesions, had all completely resolved. So considering oligoprogression status in the liver, we thought that let's give him some local therapy, and our intervention radiologist, depending on the site and size, considered cryotherapy to be a better local therapy, which was performed on 26th March. And he has been planned to continue the same regimen and has started the cycles again after the procedure. He's on cycle 31 currently and fit general condition, and reassessment after cryotherapy has been advised. So, Dr. Satish, would you have treated this patient in any other way? Is there any other option? Means this patient has done well, but there are multiple ways of treating the same patient. What would you have chosen in case the patient had come to you?
Madam, I'll continue the similar way. That same continuing the systemic therapy. Local therapy, I'll discuss with intervention radiologist whether it may differ sometimes, like it's based on the institution also. Cryotherapy we do in our institution, whether it's feasible for which is feasible, like microwave ablation or whether it is SBRT. Because those, if a localized disease, I'll try to have because TACE is not a possible at all in this case. There's already an extrahepatic disease there. Tear, like because already the major portal vein thrombosis, like tear also you cannot do that because there is systemic disease there. Local therapy in the form of is more easy is there, like going for SBRT or cryo or like a microwave is there is feasible because near to the vessel, all those things there, these should be analyzed. Then that is our decision based on that discussion with intervention radiologist, madam.
Yeah.
Yeah.
So this was the solitary oligoprogression. It was one of the site of the disease in the earlier scans, if you remember, and all other sites have resolved and patient has had progression here. And this was in scan of February. And now he has undergone cryotherapy. We have to assess after this. So I don't think so. I'll go through these questions because we have had a detailed discussion with all these questions. And the negative trials which have been for hepatocellular carcinomas. And I think this is all being discussed. Again, this was how the combinations are synergistic with PD-1, PD-L1 inhibition plus VEGF or VEGFR inhibition, or CTLA-4 and PD-1 or PD-L1 inhibition. This was the rationale for combination strategies, again being discussed earlier. This slide have been seen again and again multiple times. So I think there's not much to discuss apart from showcasing that case. So we just saw this patient journey for this particular elderly patient. with underlying chronic liver disease. It was not a viral etiology, yet he has done well with atezolizumab combination with one local regional therapy included in the treatment armamentarium. And there is a synergism of systemic and local regional therapy. We just have to see what is the right time to switch therapy if required. Thank you.
Yeah, I think very good. Response to this combination. So I think the patient should continue on this. I think most probably after undergoing this local therapy. So I think we will come to we have come to the end of this session. Thanks everyone. Thanks our all esteemed panelists, Dr. Mansi, Dr. Satish, Dr. Vishwanath, Dr. Poonam Patil. And I would like to thank our speaker, Dr. Ravi Tippeswamy, Dr. Vaishnavi, Dr. Sai Vivek, and Dr. Kiran. Any questions with our attendees are there? So we would like to take questions, if any. No questions in the charts, I think, most probably.
So there are no questions. So I think we can close the meeting, right?
Thanks
So
everyone
thank you
once again.
everyone. Thank you everyone for joining.
Thank
to
you,
all our
Srinivas sir.
academic.
Thank you, Sipla and Roche.
Thank you to our academic partner.
I'd like to
Thanks
thank
to my
our
colleagues, Dhruv and
sponsors,
Karan.
AstraZeneca and Roche. I'd like to thank our the backend team for conducting this. Thank you.
Thank you so much, sir. You're welcome, sir.